Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Welcome everyone to Mountain West AETC Echo. My name is Brian Wood and I will be doing the talk today and tackling the facilitation. This topic will be a bit of a review. These are studies that have come up on ECHO before, both in conference reviews and a couple times in case discussions. But I thought they might be worth revisiting, and I'd really like to open it up to you after I review them to see how they've impacted your practice. So we'll talk about 2 trials. I don't have any conflicts of interest or relationships to disclose, acknowledging our funding from HRSA. I will be doing my best to avoid trade names for drugs and using brand names and use generic names for the drugs. Let's start with a case. This is a real case. Just you thinking this is someone from my clinic panel in Seattle. This is a 52-year-old cisgender man, longstanding HIV, viral load, traditionally suppressed. He was taking rilpivirine, TAF-FTC combo tablet for several years. Only prior ART was a Fabrin's TDF-FTC. No past resistance. Then when the COVID pandemic started, he had a lot of turmoil in his life and was missing doses. A routine viral load check came back at 1,250. A genotype confirmed a new E138K, that's resistance to rilpivirine, and M184V, which we've talked about before, resistance to FTC or 3TC, but some reduction of viral fitness and increased susceptibility of tenofovir products. So I'm just going to put this out there for you to think about. Which regimen would you recommend? With this viral load, with this resistance, what if his viral load were 10,000? What if his viral load was 100,000? So I'm going to talk about 2 trials. Again, they've come up on ECHO before, but I thought it was worth digging into them a little bit more. And then I'd like to hear your thoughts. So why is this important? I think that traditionally, at least when I started in the field, the real goal when somebody had virologic failure and had resistance was to craft a new regimen with 3 active drugs. That was always the mantra, 3 active drugs. And I think we've learned over the years that 3 fully active drugs may not be necessary. Now, in the US, as you know, somebody has viral rebound, we check a genotype, we look at their resistance, and then we try to craft a regimen. 3 active drugs are now sometimes there's benefit to less. I will add that outside the US, which is where these studies were done, genotypes are not readily accessible. So traditionally what was done is someone would have virologic failure on an NNRTI with 2 NRTIs, and they would be empirically switched to a boosted PI. And usually their tenofovir would be switched to AZT because they might have the K65R mutation, the mutation that affects tenofovir and that increases susceptibility to AZT. So that was a very, very common practice. And now the question is, because there is increasing availability of high potency, high barrier to resistance drugs like dolutegravir, is that still necessary? So we'll talk about 2 trials. Both of these, I think, have really affected clinical practice around the world and in the US. And then again, I'll ask you how they have affected your practice. Donning, we've talked about before. I remember Dr. Harrington reviewed this after it was presented at a conference. It's come up a couple times in case discussions as well, but let's dig into this a little bit. So this study is dolutegravir compared to boosted lopinavir, each with 2 NRTIs following virologic failure of a first-line NNRTI regimen. So first-line ART here, because this was done outside the US, was NNRTI based. You can see here the parts of the world where this study was done. Adults with HIV were enrolled, all had documented virologic failure on an NNRTI based regimen. They had never taken boosted PIs or integrase inhibitors before. They all had a genotype resistance test when they entered the study, which is key, and I think we'll need to come back to, because again, that is not feasible in a lot of parts of the world. And then in this study, the investigators, the researchers at the site could choose the NRTIs to go with the dolutegravir or boosted lopinavir. So randomized to dolutegravir or boosted lopinavir, but the researchers could pick which NRTIs the individuals are going to get. Here's a breakdown of the baseline characteristics. You can see the mean age, the proportion that were born male. A fair proportion, around half, had CD4 below 200 at enrollment. And you can see About a fifth had a viral load above 100,000 at enrollment. And then you can see the NNRTIs individuals were taking when they enrolled, largely efavirenz with a smaller proportion nevirapine. These are the NRTIs that investigators selected for the new regimens. You can see there TDF, FTC or TDF 3TC, AZT, 3TC, so rather equal proportions of those options, and then a handful who received TDF, AZT. Again, why would an investigator pick AZT? Well, again, traditionally, we thought if somebody had a K65R, TDF would not work, and AZT might be the right choice. That K65R, as well as an M1A4V, really boosts susceptibility of AZT. So again, this is what was thought to potentially be the right choice. And then you can see here the number of fully susceptible NRTIs participants had in their new regimens. Of note, most only had one or two. A smaller proportion had less than one or had two fully active drugs. There were a pretty high frequency of NRTI resistance mutations in the trial, and these are the key findings. So overall, the dolutegravir-based regimen, dolutegravir plus 2 NRTIs, outperformed the boosted PI with 2 NRTIs. You can see that in the far left column. And then you can see this was especially true with baseline viral load below 100,000. With baseline viral load above 100,000, there was no longer really a discrepancy between the performance of the two regimens. But because of the overall outcome, because dolutegravir did so much better than the boosted PI, actually the findings were unblinded and all participants were offered a switch to dolutegravir if they wanted it. But looking at a couple important findings, so let's look here on the far left first at those individuals who had M184V. Again, this is the mutation that causes resistance to the FTC in the regimen, though it does hypersensitize the virus to tenofovir and reduce viral fitness some. You can see even in those settings, the dolutegravir plus 2 NRTI combo did quite well, really equally well to the situation of having no M184V. And then in this two far right bars, the XTC denotes either FTC or 3TC. So that just means FTC or 3TC. So you can see here, if someone has an M184V and they got FTC, even though that drug is inactive, people did really well. And really they did just as well as if they had a 184V and they didn't get FTC. The investigator chose to avoid the inactive FTC. So overall, dolutegravir plus 2 NRTIs seems to be performing very, very well, regardless of whether there's a 184V and regardless of whether there are fewer than 2 fully active NRTIs. And here you can see that depicted in another way. Again, the dolutegravir arms performing quite well, whether the 2 NRTI backbone is fully active or not. Now, one caveat to this, and then we'll turn to some conclusions in another study that I think added a lot of important detail, is in the dolutegravir arm, 11 participants met criteria for virologic failure, and 2 of those had emergence of significant dolutegravir resistance, whereas in the boosted PI arm, more individuals met criteria for virologic failure. My guess is there were more difficulties with adherence, but there were 0 instances of resistance to the PI emerging. So small number who had virologic failure developed dolutegravir resistance, but no one who had virologic failure on the boosted PI developed resistance to it. So something to think about. If we look at those 2 cases, those 2 individuals who developed virologic failure and resistance to dolutegravir, you can see some characteristics here. Both had pretty high viral loads. You can see the study NRTIs they received. You can see their viral load at virologic failure, and then the baseline or enrollment NRTI mutations. So I would just highlight here that no one who had just an M184V mutation developed virologic failure with dolutegravir resistance. Both individuals who did had high baseline viral loads, had 184V plus another mutation, a TAM in this first case, the K219, and a K70E in the second case, which is sort of like a weaker K65R. So again, a couple of cases of emergent dolutegravir resistance. So the conclusions here, this made a lot of headlines. dolutegravir plus 2 NRTI seems really effective, even at high viral loads, even if there are fewer than 2 active NRTIs. So it seems like if you have dolutegravir plus 1 active NRTI, individuals seem to do well. There were some limitations to this, though, and some outstanding questions. So I'll just turn to this trial, which I think was kind of underappreciated, one of the most underappreciated studies in HIV in recent years. This is called NADIA. And so this was a similar study in some ways, but different in some important measures, which I'll highlight. So this is dolutegravir versus boosted darunavir, so more relevant to our practice in the US, each with TDF3TC or AZT3TC following virologic failure, also on first-line NNRTI regimen. But a couple of differences. So this was performed here in sub-Saharan Africa. They actually allowed adolescents to enroll, though their actual numbers of adolescents who enrolled were quite small. The definition of virologic failure here was a little bit different, viral loads above 1,000 instead of 400. Again, individuals had no history of taking a boosted PI or integrase. But one thing here, it was a very practical study. So visits were largely led by nurses. They were largely done on a standard of care frequency, not a souped up hyper-frequent clinical trial frequency. And the emphasis on the visits was adherence counseling. And individuals had no genotype upon enrollment. So this is very applicable to lower resourced settings and really looks at a more empiric change if you don't know the genotype or the resistance test. And here, investigators didn't select the NRTIs. They were all randomized. And so you can see the 4 randomization arms here. Dolutegravir plus TDF3TC, dolutegravir plus AZT3TC, boosted darunavir plus TDF3TC, boosted darunavir plus AZT3TC as the 4th arm. These are the baseline characteristics. The other thing this trial did well is enrolled a large number of cisgender women who are historically underrepresented in a lot of HIV treatment trials. You can see here similar results with CD4 count and viral load in the past study, and overall a very large percentage who had the K65R and M1A4V mutations. And here's the punchline. Both of these regimens did incredibly well, even with high viral loads, even with the presence of M1A4V and or K65R. So dolutegravir or boosted darunavir combined with NRTIs, even if those NRTIs had no predicted activity, did remarkably well. So let's let you chew on that for a moment. So again, coming back to our traditional paradigm of trying for 3 active drugs, this is very different, and these regimens overall did quite well. So again, at the end, I'd love to hear how this may affect your clinical practice. I'll ask you and our panel of experts. Now, this is the 48-week data which was published, and here you can see the individuals who got with their dolutegravir boosted darunavir, the TDF NRTI backbone or the AZT backbone all seem to do quite well. Again, I think it's pretty remarkable that those who got the TDF backbone did remarkably well, even if they had the K65R. That is near full resistance to TDF, but it does reduce viral fitness and have some other effects. So this is notable. This has been touted as the end of AZT in HIV treatment worldwide. Again, I'd like to hear if you agree with that. But there are a couple other things that came out of this. The 96-week data was presented at CROI, and Jihan Budak really expertly reviewed that for us after the CROI conference. So if you want to see more detail on that CROI abstract, go back to Jihan's review from CROI from the spring. But really at 96 weeks, dolutegravir plus 2 NRTIs remained non-inferior to boosted darunavir plus 2 NRTIs. At 96 weeks, the TDF backbone actually had superior efficacy in terms of virologic outcomes as the AZT3TC. It actually really did now seem to be the better performer. But here again, 9 cases of emergent dolutegravir resistance, whereas there were 0 cases of boosted PI emergent resistance. So the question here becomes, how big a difference is there in the resistance barrier of dolutegravir and boosted darunavir? And how much should this come into play in our clinical decisions and weighing pros and cons of dolutegravir versus boosted darunavir? I would highlight that of those 9 cases who developed virologic failure and resistance to dolutegravir, 6 were receiving AZT3TC as their backbone, which in our US clinical practices we really don't use and which most places of the world are getting away from, and only 3 were receiving TDF FTC. But again, the question is, how will this affect your decisions if someone has developed virologic failure and resistance? So the conclusions, dolutegravir plus 2 NRTIs can be used as second-line ART, even if NRTI is predicted to have limited or no activity. But I think we need to understand this phenomenon of the emergent dolutegravir resistance a little better. Bocedurenavir plus 2 NRTIs also performed quite well, and no cases of resistance occurred. So finally, I'll just give this to you as food for thought. How should we apply this to clinical practice? So dolutegravir, and I would count bictegravir as equivalent, or bocedurenavir, both seem effective when combined with fewer than 2 fully active NRTIs. For example, if there's a M184V that has developed. Is this truly the end of AZT as part of HIV treatment? And what would you offer to someone who has an M184V or a K65R or both? And how comfortable do you feel giving someone dolutegravir plus 1 active NRTI or maybe even less? Should the cases of dolutegravir resistance give us pause? And if we're really worried about adherence and really want the highest barrier to resistance drug, should we be reaching for bocedurenavir over dolutegravir? I'm not sure the answer. Coming back to the case that I had shared with you of someone who developed an M184V after virologic failure and an NRTI, he had a low viral load. He ended up getting bictegravir TAF FTC as active bictegravir, and then active TAF and not fully active FTC, and he did quite well and is suppressed. But what if his viral load had been 12,000 instead of 1,200, or what if it had been 100,000? Would you do anything differently there? So I'm presenting this because I think these trials are notable and they've changed practice, and also because I think there's some outstanding questions, and I'd love to hear what you think. Last note, there was a related trial called Vicen presented at CROI, which was performed right here in Zambia, enrolled 1,200 people, was related but not published yet, and we're still waiting for the emergent dolutegravir resistance data. So we will come back to that when it is published, but that's being done by colleagues right down the street here in Zambia, and so far the results largely agree with what I have showed you.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.